Kevin, we are ready to start.
Okay, great. Well, I want to welcome everybody this morning to our Health and Wellness Committee meeting for October 4th, 2023. It is, I was seeing that it is Emotional Wellness Month, and of course it's National Breast Cancer Awareness Month. And first on our agenda, we've got the minutes that Paul had sent out before. Can somebody give me a motion to accept the minutes from September 6th, 2023? If I don't have a motion, I'll make a motion to accept them if someone could second that.
I'm sure Quentin is going to
Second.
Yeah.
Second.
Right, thank you, Quentin. Any discussion on that? Any additions, deletions, corrections? Okay, if not, all in favor of accepting the minutes from September 6th, please say aye. Aye. Any opposed? All right, the minutes have been accepted. So this morning we have vaccination updates, and I'm going to try this. Dr. Jonathan Kanuka, I hope I said that right, and he's going to give us our vaccine did I hear something? Okay. He's going to give us our vaccine updates. He's with South Carolina Department of Health and Environmental Control. So if you would, Dr. Kanuka.
Sure. Yes, I'm happy to start. Yes, and you got my name right. Most people do not, so well done.
Oh, great. All right.
So I work for DHEC in the central office of Columbia, but I actually live in Charleston. I live in the Low Country, so I'm in your backyard. I'm going to share my screen here if I can. Put together some slides here. So essentially, I want to talk about really focus on three vaccines. Not really think we have time to cover the full gambit of vaccinations and what's going on across the state, but I'm happy to answer questions about anything. But really, COVID, RSV, and flu are the main viruses that cause a lot of problems during the fall and winter months. And for the first time in history, we have vaccines for all three of them. So this has kind of been big news. And I said in my opening slide, this is kind of a tale of two worlds. So in one world, there's a lot of excitement in the pharmaceutical world, the medical world, public health world about these diseases that we can prevent. On the other hand, I think have a lot of COVID fatigue. People are tired about mandates and vaccines and requirements, and a lot of distrust of public health or the government, even though people seem to trust their individual physician or health provider. So I just kind of wanted to paint the picture of kind of the two worlds that we're essentially seeing. So talk first about COVID a little bit, and to highlight that the two major mRNA vaccines were just updated this last month, Moderna and Pfizer, and they've been updated to target XBB.1.5. This is a subvariant of Omicron that was predominant probably 5 or 6 months ago. It still is circulating, but some of its other spin-offs have become larger proportions. And so right now the recommendation is that these updated vaccines should be what people receive. Most people who are healthy should just get one dose of either Pfizer or Moderna. Younger kids who need to get more than that. People who are immunocompromised will need to get more than just one dose. But this also just came up yesterday. Novavax was also just approved or authorized, I should say, by the FDA. So they'll be coming out to market in the coming days, the coming weeks as an option as well for people that either don't want to get an mRNA-based vaccine or who can't because they have an allergy to one of its ingredients. So that will be coming out in the coming weeks and available for people to get as well. Some people have asked how good the new vaccines are. So this is data presented by Moderna to the CDC. And this is public presentation. You can find these slides and pull them, and the links are there at the bottom. But essentially what they did was they looked at people's neutralizing antibodies in their blood before they got this booster, and then after they got the booster to particular subvariants of COVID. So all the way on the left is XBB.1.5. That's again what the new updated monovalent vaccines are targeting. So before they got the boost, you can see what their neutralizing antibody level was. And then after they got their booster a month later, they checked their levels and it was 17.5 times higher than before they got the booster. The other important strain I would probably note here, besides XBB.1.16, is the EG.5.1. That saw a 14-fold increase after getting the boost, and that's another strain that's been circulating around the US. I'm going to show that on the next slide. So that EG.5 is kind of that tan one at the very top. You can see XBB.1.5 all the way on the left was the larger proportion back in June, and that's kind of diminished over time. But a lot of these over on the right, they're listed kind of in descending order from the most common. They're all pretty well related, and there's good reason to think that the XBB.1.5 will still give good protection for these other circulating strains because they're still close enough related and they have good antibody titer response as we saw in the previous slide. And it's important for these vaccines, for people to get these vaccines, particularly I would say on the kind of extreme ends of the spectrum as far as age goes. So people that are really old, it's really important for them to get, and people who are really young. And the reason why is because, COVID is still circulating, and getting the vaccines will give people that are in particular at risk for adverse outcomes like hospitalization or death, will give them that boost in their circulating antibodies. So on our website for the first time, we're actually putting out this report every week, and we just started a week or two ago tracking COVID, flu, and RSV outbreaks in school, childcare settings, and in long-term care facilities. And so you can see that for COVID, that's the main cause of the outbreaks we've had. And this is from June 25th through the end of September. So this 3-month period is very recent, but we've had 283 COVID outbreaks, most of them in long-term care facilities, but also in schools. Kids have gone back to school. They've also been experiencing these outbreaks in the school setting, and that can have a negative impact on their ability to learn. So vaccines are important for these age groups, and there's some room to make up, I think, in the AMIS population, which I'll show in the next couple slides. But this slide is just highlighting again the adverse events of the elderly population. They're that purple dotted line. This is the hospitalization rates. The graph on the left is going all the way back to March 2020, and then through August 26 to 23. And then on the right, that one is just looking at the current calendar year, January through August of 2023. So again, the highest hospitalization rates for those over the age of 75, followed by those 65 to 74, and then the very young children kind of map along with that 65 to 74-year-old age group as far as the rate of hospitalization. So again, that hospitalization rate for the kids who are under 6 months or under 2 years of age, some people say, well, they've got problems, right? They're at higher risk, and that's not necessarily true. 59 to 75% of them have no underlying health condition at all, and they're still hospitalized. But if they do have some problem, most of them have prematurity. So anywhere from about 15% to 25% of kids under the age of 2 who are hospitalized had prematurity in their background. But most of the kids, by far and away, were just healthy, normal kids. And this highlights kind of comparing, for the child age group, comparing COVID to other common vaccine preventable diseases or vaccine preventable deaths. Sometimes you hear these numbers and there's no context or a way to compare it to anything else. So this is really looking at pediatric deaths before there were vaccines available for things like meningococcal disease, varicella, which is chickenpox, and rubella. So at the very bottom, you can kind of see the comparison there. So COVID all the way on the right, for example, in kids who are under age 1, it caused 156 deaths before vaccines were available. There's nothing really to compare that to, chickenpox, 16 deaths a year. Meningococcal disease caused 8 deaths a year in the age group that was 11 to 18. So, in 5 to 19-year-olds for COVID, in comparison, it's 292 deaths a year. So those are big numbers. So even though most kids do well, that still can cause a lot of morbidity and a lot of mortality, a lot of death, just because of the way in which the disease spread. It affected a lot of numbers, right? It spread to affect the whole population, essentially. So you have high numbers of people being affected, even though most will do okay because so many people are infected, you have that many more deaths in a year. So that's why it was important for, all these age groups to get vaccinated to prevent these deaths. So just to kind of put that into context. And the rates among the under 5s, this is South Carolina population vaccination. Now we're looking at beginning of 2020 through the end of, or the beginning of September of 2023. You can really see that the pediatric population under the age of 5 is really lagging behind by a lot. 2%, 3% have completed their vaccine series. The silver lining here, obviously, is we looked at who is the highest for hospitalization and death. The groups that are 65 plus, 75 plus, they're the highest risk. And that's why that's really important for them to be getting their updated shots to, really protect themselves as things tend to peak. And so in South Carolina, that population is, 70%, 75%, 85%, pretty well covered. But now it's time for them to get their next round. And this again just kind of highlights that difference in the age as far as risk of death. So somebody that's in their 20s or 30s is kind of the reference point here at the top. And if you compare somebody that's, let's say, 75, well, they have 8.5 times the risk as somebody who's in their 20s or 30s and dying from COVID. So you can really kind of, again, put this in perspective. But again, fortunately, in South Carolina and across much of the US, the population that is getting vaccinated is that older age group. So that's a good thing. And then on the bottom, people that have some of these comorbidities also have higher risks of death. So for instance, somebody that has obesity has 1.3 times the risk of somebody who doesn't have obesity of dying from COVID. When you start combining these conditions, 2 or 3 conditions, that increases to 2 times as likely, for example, in most instances. So that's COVID. I'll touch a little bit on flu. We've had our first flu death of the season that just happened last week. It happened in the Midlands. So flu season is just starting to pick up. And unfortunately, this is a reminder, this is, I would not say a vaccine preventable disease per se, but a vaccine preventable death in a lot of instances, because, a lot of people get the flu and then they say, well, I got the shot and I still got the flu. And I say that might be true, but you didn't die. So I think sometimes we need to think about it in that way. So the red line here is showing what last year's flu season was really like. And you can see that it's much more to the left than the others. And that means that in as far as time, it was much earlier, because the bottom of this graph is weeks, is the time course. So it really started a lot earlier last year, had a very high peak, and then it kind of went down from there. We didn't know that was what was going to happen. You can see some of the other lines there from previous years. Each year is its kind of own. I mean, there's a general time frame. We usually see flu activity, but sometimes you have a high spike in the beginning. Sometimes you have more than one. So you just never really know. And so I think that's why it's important for people to recognize that September, October time is really the ideal time to get their flu shot, because we just don't know, are we going to have an early flu season or not? How bad is it going to be? We don't know, but it's very good at preventing people from winding up in the hospital. This is, sorry, let me go back. Looking at flu hospitalizations for this year. So that second line that says 2022, 2023, that year is just ending. You can see about close to 3,500 people were hospitalized this year in South Carolina, most of them elderly. About 1,900 people over the age of 65 were hospitalized. Deaths, we had 162 deaths this year, most of them in the elderly, 111 deaths in elderly, but you can see that there were also 6 children that died between the age of 5 and 17 this year. And I think these are in large part preventable. Australia, the reason I put Australia on here is because sometimes they can give us a clue as to what our year might be like. The reason is that they're in the Southern Hemisphere, and so our seasons are flip-flopped. So as we're going into winter, they're now going into their summer. And so we can look at what happened in sort of the June, July, August time was when it was their winter and it was our summer. So we can see what their activity was like. And the red line is what happened for them this year. And it looks like their red line is lining up more closely with their previous, with their average year, I would say. But last year when we had our early flu season that had that high peak, so did they. You can see that 2022 line, that's that kind of tan or peach colored line that has the high spike in the beginning. You can see they had an early flu season. So I don't want to have a crystal ball and say definitively we're going to have an average flu season, or we're only going to have one spike. But if we can look around at what happened to our friends in the Southern Hemisphere, this might give us some indication that we may have a more normal flu season this year. This is, again, going back to the need for vaccination. When we saw the early flu season last year, DHEC, we were messaging out to the public to say, hey, we're seeing these early numbers. Please get vaccinated. But looking at last year compared to the previous year's vaccination rates, there wasn't really any substantial difference between those. On average, the yellow line here is showing the overall population. On average, about 25% of South Carolinians get a flu shot. So a lot of room for improvement. The one silver lining, you can see the top line is people over the age of 65, and that's usually the most at-risk group. They're approaching 60%. It's usually around 55, anywhere from 55 to 60% of that population getting vaccinated. I think in the last few years, I don't think I've seen it get above 60. It's usually around 55%. So it's important. Obviously, it might not prevent everybody from getting the illness, but it will prevent them from the more serious negative outcomes. And I think that's important messaging for us as healthcare, public health professionals, but also providers to keep in mind too, that just because you get a shot, there's no vaccine that's 100%. Some of them are almost 100%. Hepatitis A is very, very good, but no vaccine is 100%. But we're really trying to prevent hospitalizations and deaths, and this will do a pretty good job of that. I'm not going to go through these. Are just to highlight, there's a lot of different kind of vaccines out on the market. For people that are over the age of 65, they have a little bit different recommendation because they should be getting high dose flu or an adjuvanted flu shot that helps them mount a better immune response, because their immune systems, as we age and we all get older, they aren't as necessarily as robust, and getting these other vaccines helps increase the immune response to flu. So it's a little bit of a different population than the rest of the population. That's why there's these kind of separate vaccines for the 65 plus group that are maybe a little bit better for them. And you can see, again, this is looking at flu vaccine effectiveness. Overall vaccine effectiveness is on the left. So that's all ages. And this is, when we say vaccine effectiveness, this is looking at its ability to prevent symptomatic disease, not its effectiveness at preventing hospitalizations or deaths. So sometimes you got to specify when you say vaccine effectiveness, where are you measuring its efficacy for preventing symptomatic disease or its efficacy at preventing, or effectiveness at preventing hospitalizations. So overall for the population, it's usually anywhere from 20 to 50% in a year preventing symptomatic disease. And you can see for this on the right column, for the people that are over 65, they don't mount as good of an immune response for all types of vaccines. So that's why, in more recent years, you started to see these more, as I showed in the previous slide, more tailored vaccines that are adjuvanted. An adjuvant is just something you add to the vaccine to help the body mount a better response. So it's either adjuvanted or just a higher dose of the antigen in that vaccine. And looking at what happened in Australia, it looks like the flu vaccine, we have 4 strains in the flu vaccine. There's 2 A strains, H1N1 and H3N2, and then there are 2 influenza B strains. And it looks like there's a pretty good match of what was circulating in the Southern Hemisphere, anywhere from 83% to 98% for a couple of the others. So we don't know the vaccine effectiveness for that vaccine, but essentially the WHO helps select the 4 strains that are going to go in the vaccine, and then the manufacturers get those 4 strains and they put it in their platform, and then they offer it to the masses. So each product is essentially targeting the exact same strain. They just have slightly different, components and ingredients. And last, I was just going to go over RSV. So this is a respiratory syncytial virus. You might have heard it called, but that's the most common cause for hospitalizations in infants, particularly in their first few months of life. And if they have underlying conditions or respiratory problems, that also increases their chance of hospitalization. So this slide here looks at the hospitalization rates over the last year by age group. So that highest peak is for kids 0 to 17 years of age. And you can see the scale on the left, the rate is approaching 20 children per 100,000. And then the next closest one underneath that is the group that's over the age of 65. So on the next slide, I just want you to follow, if you can, this 0 to 17 is going to drop down. There's going to be a pink line that jumps up that focuses in on the youngest infants under the age of 1. And then you'll see the scale on the left increase by a fold of 10. So you can see how important it is for the infants. So again, now we're looking at approaching 200 infants under the age of 1 per 100,000 infants getting hospitalized. And that overall group of 0 to 17, you can see drop way down. And then you can see underneath that, the elderly population, the over 75 group is at higher risk than the over 65 group underneath it. But again, you can see that the infant population far outstrips anybody else. And this is looking at what we're seeing right now for RSV activity in South Carolina. So this is looking at the percent of PCR tests that are done in South Carolina for RSV, the percent that are positive. And so this is looking at for the last 2 years. So you can see kind of that first spike all the way on the left. That was from 2021. And then the spike in the middle was last year. And we're not seeing too much quite yet. That was the end of September, but I expect that'll start going up because usually RSV season runs October through March. So this is kind of the prime time for people to get their vaccines. Although COVID did sort of mess up the usual pattern, you can see in the middle here, all the blue lines are the dotted lines. That's the normal RSV season. Again, October to March, the time frame is on the bottom. But the 21, 22 year and the 22, 23 year, you kind of see those, that was the COVID years. The RSV trend was a little bit different. So we'll have to see what happens this year. If we get back to more normal year, it kind of looks like it based on that graph I showed you before, what was going on in South Carolina. We haven't really seen an uptick quite yet. So we'll see how this year shakes out. But this is the time for infants to get their vaccine. So all infants in their first RSV season, which again is October to March, who are under 8 months, should get this immunization. I put immunization in quotes because this immunization is actually a passive antibody and monoclonal antibody. All other vaccines are designed to present some form essentially of the antigen or the pathogen you're trying to prevent, and your body makes its own antibodies. Whereas this immunization for infants already gives them the antibodies directly. There's nothing for them, for their own body to make. So that's an important age group. And then other kids who are at higher risk in their second year could get an immunization as well. Last week or the week before, the CDC also approved a vaccine for pregnant women, which the idea is that the pregnant woman mounts a response, their antibodies pass through the placenta to the infant, and then that infant is protected during the kind of September through January time would be when the pregnant woman would get it. And then adults 16 and older could also get an RSV vaccine. So the RSV vaccine for that group and for pregnant women is essentially the same. This is just to highlight what those different products are. There's one from GSK and Pfizer, and we're looking at the efficacy against severe disease. So I talked about effectiveness and efficacy, what you're trying to measure. So most of these, all three of them are about 80% very good at preventing hospitalizations. So that's what they're looking at for the efficacy measure. So that's the positive world, I guess. In one sense, I said, we're kind of this is a tale of two worlds. So we've got these great advancements, great ways of preventing hospitalizations, great ways of preventing death. And then the other world is that people just aren't that interested, right? I think people are just fatigued. They don't have time. They don't care. They don't think that the disease is severe enough. They don't think that they're susceptible. They don't perceive the benefits as being good enough. There's all different reasons why people choose not to be vaccinated. But the National Foundation of Infectious Diseases did a survey of adults this year about flu, COVID, and RSV, and asked them, well, how concerned are you about getting COVID or flu or pneumonia or RSV? How concerned are you about your family getting it? Less than 25% were concerned across the board about getting any of these. So less than 1 in 4 Americans were concerned about their family getting any of these illnesses this year. Even though we've got hundreds, thousands of people that are going to be hospitalized and dying from these across the state. So only 40% of older adults are planning to get their RSV vaccine. 40% of adults are planning to get their updated COVID vaccine. 65% recognize that flu vaccine is a great way to prevent hospitalizations and death, but 43% say they don't plan to get one, or they're not sure if they're going to get a flu vaccine. So there's this, disconnect. Part of it's lack of trust. Part of it's concern about the safety or the side effects, or thinking that they're just not effective, or that they're going to actually get the disease from getting these vaccines. So there's opportunities for education. A lot of that happens in the actual clinical setting. And unfortunately for the older the adults that are maybe at higher risk or have underlying conditions, they're not planning to get a flu vaccine either. So that's all a bit unfortunate. But one of the things that we've been working on doing in South Carolina is providing education to the vaccine providers, providers that maybe have low uptake in their counties. We've been doing motivational interviewing trainings to help nurses, help physicians understand their importance in providing strong recommendations and providing education, because still those people are the most trusted for vaccine information, whether it's for flu or COVID or routine immunizations. There's still that one-on-one relationship is really the most trusted, and that's really important. We're trying to lean on that as a health department and encouraging pediatricians and providers to provide that strong recommendation and counseling when they have those opportunities. So just to highlight again, we've just started our season. We don't know how bad it's going to be. Flu season, you've seen one flu season. We don't know, we've had different COVID spikes. Looks like RSV hasn't picked up quite yet, but we've got these vaccines available. But it seems like for various reasons, people aren't planning to get any of these vaccines. For the most part, the majority of the population won't be receiving these. But as much as we can, we're providing education and information and try to provide opportunities for vaccination and uptake. So that's why I just wanted to share this morning, and I'm happy to answer any questions if anybody has questions about these vaccines or any other vaccine.
All right, thank you, Dr. Kanaka. Any questions?
I have
Paul?
a quick question. This is
Quentin, go
Quentin.
ahead.
Yeah. Are you all planning at DHEC to do any community flu shot clinics, actually traveling out into the community, or is everyone asked to come into your clinics? I get a lot of calls for that at MUSC, so I want to compile my resources and know who I can refer folks to. I didn't know if there are any plans for that this year.
Yeah, I'll just give a general answer, then just kick it over to Dr. Richardson to give maybe more specifics. But we do have some partnerships with various groups across the state. We're doing, mobile vans, where we got grants working with, Clemson and other groups to provide opportunities for elderly people with disabilities to get flu and COVID, but also other routine vaccinations. But I'll let maybe Dr. Richardson in the Low Country or the Charleston area specifically.
Thanks for that question, Quentin. We do have our team that has been giving COVID vaccines will now also be able to provide flu vaccine along with COVID vaccine at community clinics. So we do have a coordinator for those clinics, Evelyn Fernandez, and I will pass along her contact information to Paul to put in the minutes. But that would be the person you could give to community groups who are interested in having an event at their organization or associated with some sort of health fair, that sort of thing. And she could work to get that scheduled.
Thank you. Certainly appreciate it.
All right, I think Paul Wieters has a question.
Doc, the question I had was, usually y'all get predictions of flu from coming across the ocean. I think it starts in Australia or something. Is there any strong indication this is going to be a really big, strong flu season?
It doesn't look like that they had a more active flu season. It didn't seem like it came earlier like it did last year. So it looked like their activity was more typical as it was in the past, not that early spike that we saw last year. They had that as well, but this year they had it looked like a more normal flu season. So again, that was their experience. That is probably a good marker for us, but it's not a perfect crystal ball, but it's probably at least something to be optimistic about.
I'm gonna go back to the COVID, and I'll talk about a little about flu at the same time. Preventions that people can do with symptoms. We hear the mask issue back and forth. What would you best give us as advice for people both with flu and COVID symptoms, other than to stay home?
Well, there are treatment options available for both of those, depending on your underlying health and risk factors. That particularly if you're early on in your flu course or your COVID course, there are different medications that are available, and I would encourage people to talk to their provider if they're interested in exploring those options, because there are treatments that can help shorten the severity of illness and help people kind of get back on their feet more quickly. So there's Paxlovid and there's remdesivir and there's Tamiflu. There's different medications for flu and COVID that are options that people still get COVID and they're concerned about their health and what that might mean for them.
How about the mask wearing?
That I think is really an individual choice. I think that well-fitted, high-quality masks can provide some protection for some of these respiratory illnesses and these viruses that are circulating. So I think for, I know some people that they're at higher risk, or they have family members that are at higher risk and they're concerned and they want to put something on when they're in close quarters and concerned about things circulating. I think that's up to them. I think it provides some benefit. But it's really, I think, an individual choice of what people want to do at this point. I don't think you're not going to see a broad recommendation from DHEC for that at this stage. I think people have enough level of immunization from either having had COVID or been vaccinated against COVID that you're not going to see these high numbers that we had in the past before vaccinations were available or people had been infected. So I think that there's a significant proportion of the population is walking around with some level of immunity. It may have waned over time, but I don't think that you're going to see the need for N95 or K95 mask wearing recommendations coming out from the health department.
Any other vaccination questions or? Okay, well, if not,
I'll email you a copy.
Oh, great. Thank you very much. Appreciate that. Lot of information in a little bit of time. We really appreciate you being here and sharing this information and helping to keep our community healthier. So thank you so much for all that you do. I appreciate it.
You're welcome. Thanks for having me.
All right, so we'll move on to our community health update, and Dr. Katie Richardson is on with us, and she'll give us that, if you would, please.
Thank you, Councilman Shealy. Just to put one more plug in there around COVID, and that is the COVID tests are great to have around. That way, if you have respiratory symptoms, you can quickly know with an at-home test whether it is COVID or another virus. Those tests are free of charge at any DHEC health department, and they can also be ordered from the federal government again. And I sent Paul the website for doing that. I've done it myself. It's easy. They haven't come in yet, but hopefully will arrive in the next couple of weeks. Also, if you have COVID at home test and there's an expiration date that it's already passed, there's a different website that you can go to check and see if those expiration dates have been extended, and they have for most of those tests. So before you throw them away, check the website that Paul will also be able to provide for that information. And then in addition to COVID test, we continue to have naloxone or Narcan available for pickup at any DHEC health department. Our WIC program, Women, Infants, and Children Nutrition Program, has begun seeing clients again in person. So during the COVID pandemic, our services moved to virtual only. That will continue, and based on client preference, they may receive services virtually or in person. We had a lot more interest in WIC with the virtual option, and so we're glad that the federal government is allowing us to keep that going. So if there's interest in a WIC outreach event where we'll be able to help register new moms and moms with young children, please let me know and I can make that connection. I wanted to talk a little bit about rising STI or sexually transmitted infection rates. Unfortunately, South Carolina now comes in as third in the nation for the highest rates of sexually transmitted infections in our state. We're number 4 for chlamydia, number 5 for gonorrhea, and number 20 for infectious syphilis. And those numbers have really increased over the past decade, with 17% higher rates of chlamydia, 65% higher rates of gonorrhea, and 148% increase in syphilis rates. And that really means that compared to a decade ago, a person now has a 2.5 times risk of contracting syphilis than they did 10 years ago. We're seeing the majority of these cases in adolescents and adults under the age of 30. And so really our message is talk, test, and treat. So this is talking about it, making sure that that the public knows that these rates are increasing. Testing is very important, even for those without symptoms. And then there are antibiotic treatments that they're able to cure these infections, but first the person needs to know that they are infected. So testing can be done with your primary care provider, as well as at DHAC clinics, and so please take advantage of those options. And lastly, I just wanted to touch on hepatitis C. So that is a viral infection that affects the liver. There are a couple of different kinds of hepatitis infections, but this is one of the most common, and it is now curable. So that is really a medical breakthrough that happened not recently, but we're really working to get the word out about that so that more people can take advantage of that treatment. It's a fairly easy course of treatment. It's medications taken once a day for either 8 or 12 weeks, and that produces over a 98% cure rate. So screening is recommended for everyone over the age of 18 at least once, and for those at high risk, yearly screening is recommended. And those are people that continue to have risk factors for contracting hepatitis C. Those include anyone who uses or injects drugs, anyone who may be experiencing homelessness, those who are on hemodialysis for any reason. And again, the test is an easy antibody test, blood test that can be done with your primary care provider or at DHAC. And then there's a referral to an increasing number of providers who are easily able to treat that for a cure. Without treatment, 10 to 20% of people will go on to develop cirrhosis, which can be a deadly sort of consequence of hepatitis C. So those are a few of the things I want to mention today, and I'm happy to take questions on any of those, as well as any other questions around public health and DHAC.
Any questions for Dr. Richardson? Paul?
Not a question, but again, if there's some information that we can help share out in social media or through our public information, if y'all would just please forward it to us. And Katie and I talked that we're going to meet here coming up because we really need to also get back on our fast track cities long-term planning of what kind of task force we need to do to make sure that we hit our goal of 2030 of trying to get up to 95% of our people recognizing, getting them tested and treated. And so that's something we all need to work on, and we need to call on the community and all the stakeholders to be a part of that whole process. So I don't want to let us walk away from fast track cities because it's too important for us to address everything she just talked about in these numbers.
Thank you, Paul.
And Dr. Richardson, when you're talking about the hepatitis, when somebody has hepatitis, do they know they're really, really sick at that point? Or, is it something you can ignore, or is it something you just know you need to get help with?
No, it is often what we call asymptomatic, or many people do not have any symptoms at all until they start developing those symptoms of cirrhosis. And so that's why it's so important to be screened with a simple blood test, looking for the antibody. And then some people do clear it on their own. So once you have the antibody, then we follow that up with a viral load to look to see if the infection is active, and also to look at liver function tests, which really show if the liver is being affected by the infection, and go from there. So great question. Thank you.
Great. Thank you so much.
Any other?
Stacey, go ahead. Go ahead,
The
Stacey.
treatment for hepatitis C, is that covered by most insurance and Medicaid, Medicare?
It is, yes. And in fact, we're very grateful Medicaid in South Carolina just changed their regulations so that it's now easier for primary care providers and others to treat for hepatitis C. At one point in time, there was a need for like a specialist consultation, but it's really such an easy regimen with really few side effects that our infectious disease and gastroenterology specialists now know that primary care physicians and there's a great sort of telehealth service in South Carolina where any primary care physician that has a question can use this service free of charge to get any guidance they may need. But no, really anybody can treat for hepatitis C, and most insurances do cover it.
Great, thank you.
Yeah.
Any other questions for Dr. Richardson? Well, as always, Dr. Katie Richardson, thank you for all your information and all that you do for this group. Thank you again. We're going to move on to our update on White House Challenge to End Hunger and Build Healthy Communities. I'm going to call on Paul Wieters.
Thank you. Let me get this. After our last meeting in our group talking about the wanting to support this, the mayor asked that I go ahead and fill out the application and send it in. So I just wanted to take a few seconds to I promise no more than 3 to 4 minutes, but to go through a little bit about what we put into our application. I have to thank Joey Kern and Nick Osborne for being my resources to do this. I left Katie out of this one, but I gave her a break. But Nick was so helpful in helping me to pull this together. But it involves our whole community. And so I wanted to just go through it and just show you a little bit about what we put in our application as we look to go as for the next couple of years, how we can in Charleston work toward making a difference. So you know the 5 pillars described below define the scope of the White House Conference on Hunger, Nutrition, and Health. Improve food access and affordability, integrate nutrition, health, empower all consumers to make and have access to healthy choices, support physical activity for all, and enhance nutrition food research. Our approach to this was they asked us for a proposal. So what we came up with, and this was to, first of all, raise awareness and understanding around the importance of the intersection of health, transportation, which we talked about last month, housing, and food security for parents and their children. The key is this develop some key talking points that the mayor could regularly include in the many engagements he has to share his voice and influence to raise awareness and push for change. Some of those key items would be reminding everyone that food insecurity rate amongst children in Charleston County is 9% over the 7,000 children in Charleston County. The importance of transportation and its impact on access to food and the need to invest is in its improvements. That we emphasize the importance of health service providers screening for food insecurity and providing options for patients who screen positive. This could help include setting up on-site pantries and food pantries and pharmacies. The importance of recreation and green space for children and the need for this is in any current and future developments we stay focused. So suggestions of what we recommended was in 2024 that we would conduct a needs assessment to identify who the current providers, organizations, agencies are in our community that are working on food insecurity and hunger. And not only do that, but then find a place to provide that so the public can find it, that it has a standing place on the internet or at anybody's disposal. So it's very easy to find and can continually be updated and be a beacon to help people. then bring those members and community stakeholders and leaders, our CEOs and our council, to the table to develop a local action plan that could dive into the grassroots and not only identify the why, but develop the how. Using the needs assessment, we could develop and provide, as I said, a Charleston City resource that captures all the organizations who are working on these different issues for residents to access. Also, we could identify the relevant stakeholders, bring it all together to discuss the issue associated with disparities around access to resources and services. And our timeline would be 2024, convening the stakeholders and doing that needs assessment. 2025, developing the strategies, with really 2026 looking that our strategies are incorporated into our city planning. The fourth part of the discussion that we had was that we needed to engage the local and state in the challenges to end hunger. So in 2024, the mayor would call on all South Carolina mayors to support legislation providing free breakfast and lunch to all students. Some of the benefits of this include ensuring all students are hunger-free and ready and able to learn, reduce stigma in the cafeteria, and school meal debt, eases administrative burdens, supports innovative service models, and advances racial equity. Finally, the last two questions that we had was, how would we describe the specific populations? And we really stayed very general because the emphasis is on our children, but it will be inclusive of our growing populations in areas that we have identified where we have these health disparities. Our plans to measure the progress and impact of commitment from nutrition and food insecurity will work with our local providers like Low Country Food Bank and others to determine the impact made to feed children to schools and community to reduce the percentage of children facing food insecurity in our county. And then finally, physical activity in community gardens and open space. We will look at access for all our communities to their nearest green space and increase in our park usage programs, as well as comparisons to state and federal metrics for our city. Those are pretty generalized in the end, but if you'll see, the impact of this is we have to do something and not just sit on the sideline and let others carry that torch. We have to be engaged. And so with that, that's a brief of our little projection to the challenge of how City of Charleston can be engaged in it. And I'm full of enthusiasm to say, tell us more or tell us what you think, because we do have a couple days yet to finish up this application, but it is important that we do make the dent we want to do to end hunger, and it starts right here. So thank you.
Great, thank you, Paul. Any questions for Paul? We appreciate all the work that Paul's doing on this. Joey Current and Nick Osborne, obviously working very, very hard for our community and helping with this. And appreciate Paul giving that update and all the work that all three of them are doing to make all of this happen. So if there's no other questions, we'll move on to the health and wellness updates. I guess if you'll just kind of raise your hand, I don't want to put anybody on the spot, but if you've got a update that you want to give, we would be glad to hear from you.
Hi, this is Susan. I'm
Hey,
sorry.
Susan. Yeah, thank you.
I'm on my phone. I'm not sure how to raise my hand on my Zoom on my phone, but I thought I would just jump in real quick. I just want to let everyone know that we've got our South Carolina Healthy Business Challenge Fall Seminar Series coming up. And our keynote speaker, really excited to feature Ben Toll, who is owner of Basic Projects. You're probably familiar with the Post House and Basic Kitchen and their fish camp out on Sullivan's Island. And he is a really dynamic speaker and is going to talk about how he has created a culture of well-being in an industry, in the hospitality industry, which is typically really struggles with that, and how he really focuses on not only health and well-being, but community engagement. And then he's going to talk about his rowing across the Atlantic with his chef and just a lot of other things that they do. So I would love for y'all to help spread the word. The event in Charleston will be on Wednesday, November 1st at the Harbor Club. And just as a reminder, that is free, sponsored by Blue Cross Blue Shield. And we also have the same seminars as we expanded statewide. I know I shared with this group earlier this year. We launched the Midlands in May. So we are now in 3 regions across the state. So if you have colleagues in Columbia in the Midlands or in the upstate, October 18th, we'll be in Columbia at the Palmetto Club. And then on the 19th in Greenville at the Thornblade Club. So I will send that flyer and the link so y'all can register and share with your colleagues.
Susan, thank you for all that work that you're doing on the Healthy Business Challenge. But could you just maybe touch a little bit about any updates on the heat index that y'all been studying?
I don't have the latest on that. I will happily take that on and bring it back at our next meeting, if that's okay.
I appreciate that. I have just been watching and seeing some things that different. So when the city was doing the peninsula plan, and it's just amazing over the work that y'all done. That I just want to make maybe that's a presentation we do somewhere in the future to just update us. Because in our November meeting, we're going to have the Veterans Association on site to talk about veterans and help with them. So we'll say.
Sure, I'm happy to do a presentation when I'm more prepared.
Okay, thanks. I should have asked you earlier.
Great. Thank you, Susan Johnson, for all your work and everything you do for that update. Thank you. I see Stacy Mathis has her hand up.
I just wanted to give you a quick update. I'm not sure if Jen has mentioned this before. South Carolina is undergoing a review of all the public health systems. And we did have a visit last month from a group called BCG, which is one of the groups that's tasked with looking at sort of potential reorganization of the public health agencies. They're meeting with and talking with folks across the state from DAODAS and DDSN and mental health and sort of all those agencies across the state. I think it really went well sort of from our perspective. What we heard from them is that Charleston tends to be sort of that area that the other parts of South Carolina may not necessarily have sort of what we do here in Charleston. And a lot of that is because of the relationships that we've built. So it was sort of affirming for us to hear that kind of this type of forum, all these relationships that we have, especially mental health and Charleston Center. Apparently other agencies were sort of pointing to that relationship as, you know, a really positive that other areas don't necessarily benefit from. It is, so that was good, sort of kind of a pat on the back for us. It is a little concerning what the outcome of this whole investigation or, you know, kind of deep dive into public health is going to mean for us as an agency. This isn't really necessarily the first time we've looked at this. It keeps coming up every few years, but we'll see. We'll see what happens after that. And they are still looking. They may be reaching out to folks. Jennifer gave some names to them as to people that they could contact to talk about, you know, Charleston Mental Health Center and how we operate and what's going on. So we're just sort of waiting to see what the outcome of that's going to be for, you know, for our agency specifically, but also, you know, for DAODAS and DDSN and all those other agencies.
Great. Thank you, Stacy. Any questions for Stacy Mathis? Well, thank you for all the work you do, and thank you for reporting out to us there as well. We appreciate it. Anyone else under community health and wellness updates? Anybody else? I did want to say that you may have seen this in the chat, but Maggie had to leave early. She did want to mention that they have the Charleston County Schools has a family data conferences that are coming up in November, and please look for more information from your child's school in the coming weeks. And I thought I would mention this too, to this committee. There is a referendum that's coming up on the ballot for people who live in the city of Charleston, that will be up on the November 7th ballot. And it's a Parks and Recreation bond referendum to spend $70 million to expand and improve our parks in the city of Charleston. City council left that up to the voters to decide. But I think everybody feels like it's very, very important. We need to do a lot of work to our parks, and we need to expand our parks. And there's a lot of things on there, but it's a very detailed list of what that money would go to. So I encourage everyone to take a look at that. You can go to the City of Charleston website and search for it and find it. And I can certainly send that list out to this group as well. But as far as health and wellness, obviously our parks play a very major role in that. Again, it's left up to the voters whether to spend that $70 million on our parks, but it is an important referendum question. So I hope you'll take a look at that. If you feel like you want to, that you're in favor of that, I encourage you to talk to your neighbors and your friends and anybody that lives in the city of Charleston, and have a discussion about it. So thank you for letting me say that. Anything else? Any other health and wellness updates or anything else to come before this committee? I want to say thank you to everybody for putting your time and helping make the city of Charleston and our area a much healthier place. We appreciate everybody's expertise and all that you do for our community. And thank you for spending a little bit of time with us here today. It makes a big difference. So if nothing else to come before this committee, we stand adjourned.